Hey everyone, Bridget here at the AEFE Training Center. We are doing some lifting threads on my patient today. So we are going to start out with marking the patient up. So as you can see, I have already done that, but I had her sit all the way up and then I kind of just pull wherever she's getting the best lift. So I'm always going to enter for my 3 vector along the zygoma. And then I decided to also do a jawline on her, and then also we are going to move down to the neck. So as you can see, what I just did is I numbed all of the pilot sites with lidocaine and epi. So I did a little bit at each pilot site, one on the zygoma, one kind of over the masseter, and then one on the neck. So now I'm going in with my 2% lidocaine. I actually add a little bit of sodium bicarb to help with like the burning sensation that lidocaine can cause. So I'm going to deliver no more than 0.5 cc's of lidocaine in each tract. If you do a little bit more and there's more liquid, then there's risks that the threads will not, kind of engage with the tissue like you're wanting them to. They won't get as good of a lift because they're not really able to grab onto the tissue because there's so much liquid. So I kind of do things a little bit differently, especially in the nasolabial fold. I never go past the actual nasolabial fold. One reason I don't like to is because if you go past the nasolabial fold, it's very, very difficult to stay in that subdermal space, because you're going from a really nice volumized cheek to essentially very, very thin skin around the mouth, which is definitely not going to look the same when you are trying to find the accurate depth. So I have started just kind of like ending before the nasolabial fold, and I've actually gotten a better result doing that than going past the nasolabial fold. So once I have all of my threads in there, I used 19 gauge by 100 millimeter VSoft lift threads. These are the Arte ones. They're probably my most used lifting thread out of all of them. I really, really like them. This patient probably could have used a little bit thicker of a thread, but I just decided to go with this one today. So I decided to do 2 to her nasolabial fold and then 1 to her jowl for more prevention. She doesn't really have any jowling currently, and she also doesn't have any marionettes, so that is why I decided to not do that. But you can see my cannula underneath her tissue where it's in a straight line, and you can see that my line that I previously drew with the marker is very curved, so that's giving the appearance that she got a really good lift. So when I sit her up, the result will be pretty noticeable. So that's always a really cool trick, that if your line kind of isn't where you put it originally, that you got a great lift. Sometimes I will do 2 threads to the jawline if I don't do a marionette in my 3 vector, just because it will help tack that back, but she didn't even need that, so I just decided to go with 1. Now we are moving on to the neck, where I'm again starting with my lidocaine and epinephrine. If your patient is like super anxious, like some patients are really weird about getting epinephrine, you can also use 2% there. I just like it with epi because it helps kind of cut down the bleeding when you are using such a big pilot hole needle like this 18 gauge. Some people even use a 16 gauge pilot hole needle, but we just don't have those. So I've been using 18 gauges since I started doing lifting threads, and I haven't had an issue. Even when I use the 17 gauge threads, I never really struggle getting in there. So I entered prior to my SCM, so a little anterior to that. If you enter over the SCM, it can cause the threads to work its way out. It can be uncomfortable for the patient when they turn their neck, so that's why I enter more centrally than over the SCM. Obviously, precaution-wise, you have your carotid right underneath of you. Again, you are very, very deep, so it's not really much of a concern, but just being aware that that is under there, and that your patient can bleed a lot more in the neck. So I do really like using epi in the neck just because of that reason. If I'm ever doing filler and threads, which I don't really do that, but if I was, I would be weary about using epi in my lidocaine just because I would not want the blanching if I'm doing filler in a similar area, just because it would, freak me out a little bit and thinking that I have a vascular occlusion when it's just the lidocaine. Once I have all of my threads in there, I trim them just with a sterile suture kit. It comes with a pair of scissors, so that's what we use. And then I trim all of them down, and then you'll see that I will take some arnica, and I'm basically just going to rub out any of that dimpling. I always make sure to educate my patient about what they can and can't do afterwards, so no exercising for a full 2 weeks. They can they can walk and jog and do like yoga or Pilates. I'm fine with that, but no heavy weightlifting, so no like squatting, no, going to the gym and like lifting weights, like bench pressing, anything like that. I do not want any tension on the face, but I'm completely fine with like light exercise. But I always make sure to educate them that dimpling can be very, very normal, and just because the threads aren't settling, that's okay. The threads eventually go away altogether, but they will start to settle out over the next 4 to 6 weeks. So I always, kind of give them that confidence that that's okay if that happens. If it's really bothering them, you can try to smooth it out, bring them into the office, or you can also have them apply heat to the area. Heat will break down the threads quicker than, the natural process. And then at the very end, just to keep everything nice and clean, I put on some Band-Aids, and then your patient is ready to go, and your patient will leave these on until the night of. Thanks so much for watching.